Thank you for the opportunity to talk about arthroscopic scaphoid non-union bone grafting open reduction internal fixation. My name is Eric Wagner. I'm at Emory University. I'd like to thank my co-authors in the production of this video. We have nothing to disclose that's relevant to this video. This is kind of establishing the 6R portal after viewing through your 3-4 and ultimately exposing the radiocarpal joint. And this allows us to examine what other damage might happen. You can also start to see that proximal pole of the scaphoid, debride some of the synovitis that's present there, and ultimately start to kind of where you can start to see some of the fracture line there and assess if there's any sort of articular damage or cartilage damage here. Make sure that there's actually the cartilage cap. You can see here the cartilage cap really has been disrupted. Now we are establishing your MCU viewing and MCR working portal. We're kind of debriding out some. You can see this is a type 2 lunate, and you can see the SL. You can actually see the fracture non-union site with that cartilage cap clearly intact right next to the scaphoid ligament. So there's the SL. There's your non-union. So there's your SL. There's your non-union. You can see how close that non-union is to the actual SL. And you can see how the SL and LT ligaments look just fine, very nice and stable. So now we're using a arthroscopic shaver and then eventually an arthroscopic burr to sort of take down this non-union site. So you can see here how we're taking down the non-union, taking down some of that fibrous tissue really nicely and really thoroughly. You want to get back to bleeding bone, get rid of all the fibrous tissue. So I'll start out with a shaver, and then I'll eventually progress to a burr. These are both 3.0 millimeter size, just to allow us to easily take down all this. I do like to get back to bleeding burr. Obviously, with this proximal one, you have to be careful on your proximal part of the takedown. Make sure you actually saw bone left for your fixation. But the nice thing with doing this arthroscopically is you can clearly see how much you take down. You can take down just enough, but potentially not too much, especially in these proximal poles. And you can see how you're looking right down the fracture site of this. I'm very carefully taking down some of the bone on that proximal pole, but I'm also I'm going to leave enough left for us to actually have some good fixation. So there you can see we've debrided out pretty thoroughly, and I've got back to some bleeding bone on kind of both sides. So then I just use the soft spot of the distal radius, and I will harvest some of this bone just adjacent to the Lister Super. I like to use the bone graft harvester as well as a curette. And then I'm going to arthroscopically visualize this, flexing the wrist forward a little bit. I can place a derotational K-wire, make sure I'm in that very little proximal fragment, make sure I clearly place it. And then once I'm happy with the overall reduction, I can then visualize and place a screw, or I can use K-wires for this, or however you want to fix it. In this case, I'm going to use a guide pin. I'm trying to aim right down the axis to make sure I catch adequate amount of the actual fracture itself. You can see how you can do this arthroscopically and visualize it as you're placing it directly into that proximal pole. So here I'm placing it. Sometimes I actually will advance it out the volar side and then place it back through the volar side. In this case, because the proximal pole, I actually want to place it through the dorsal side just to make sure I capture it. So I'm viewing through 6R. I'm placing this through an accessory portal. And you can see how we're placing that perfectly below the subcondylar surface. And then if I can either keep K-wires in place, or if I want to place a smaller second screw, I think that's also a very reasonable option. In this case, you can see what we're doing is we are going to place a smaller second screw because I want to get sort of as much fixation as possible in this really proximal pole. And these, you'll probably have, if you're going to try to go for 2 screws, you'll want to use ones that are smaller, and make sure you have enough actual real estate in that proximal pole. You also want to make sure it's beneath the articular surface, and make sure there that there's not going to be any risk of some prominent screws once it actually heals. So you can see here we have the 2 small screws that's about 2.5 millimeter in diameter. And then what I'm doing is passing some bone graft into there, and then I'm squirting some fibrin glue to hold the bone graft in place. So I initially first we'll fill this through the mid-carpus, fill up the bone. I placed a little bit before I actually place the screws, and then I'm placing the rest of it after I place the screws, and this sort of allows me to really pack that non-union site and fill it up basically as full as possible. So once again, you do a little bit before you place the screws, and then after you place kind of the guide wires to reduce the fracture, and then you'll place the rest, as you can see here, after you place the screws, really filling up that non-union site and packing it. In this case, I'm using a mosquito. You can also use a flat kind of elevator. So that looks like there you can see the autograft that's packed in there. You can see the screws that we placed. I did place some fibrin glue to kind of hold it in place. And on the post-op exam, you can see the patient did pretty well, pretty good fixation of this fracture. Ultimately, he healed this non-union and got back to pretty functional level. So thank you for your time. Thank you for your opportunity. Please reach out to me if you have any questions.